Mr. Kayano, please you have the floor.
Thank you very much, Nishikawa-san, for your introduction. Good afternoon, everybody. First of all, let me offer the sincere condolences to the victims of the Noto earthquake and other disasters in the world. Thank you, Paul, Nishikawa-san, and UND IRP colleagues to invite me to be here. And it's my pleasure to contribute to this important event. This is very timely to discuss recovery. Recent years, many disasters, natural disasters, and humanitarian events, a lot of things occurred in the world. And we need to consider how to recover effectively, evidence-based approach. And it is an honor to be the moderator of this event. So as a moderator, let me introduce myself first. I am a technical officer of WHO and Secretariat of the Health Emergency Disaster Risk Management Global Research Network, and working for the research on health emergency disaster risk management in collaboration with many international and local universities and research institutes. And today's speaker, Professor Kanbara, also supported WHO initiatives and activities on disaster risk reduction and health EDLM, and I have known her for years. And I appreciate her contribution continuously for WHO and other related activities, and happy to moderate this session. Then also, as a moderator, let me briefly introduce her, which is already written in the handout, but very quickly introduce her. She is one of the world leaders of the disaster nursing, and she contributed to the many global, regional, and local community activities on health and disaster, with substantial efforts for interdisciplinary and multi-sectoral collaborations. And she's also a well-known researcher on disaster and health, and has worked for multiple universities in her career, including Kochi University and Hyogo Prefecture University, and currently working as a professor for the Kobe City College of Nursing. And also she is a pioneer of introducing epidemiological thinking to the disaster nursing field, and is the founder of EpiNurse. And she's also the organizing the World Society of Disaster Nursing Conference in 2024, November in Kobe. And she won this award of Global Platform for DRR in 2017. Today, she will talk about empowering community-based disaster management. So, Professor Kanbara, the floor is yours. Thank you.
Okay. My name is Sakiko Kanbara. Good afternoon, everyone. My name is Sakiko Kanbara from Kobe City College of Nursing. Today, I'd like to talk about empowering community-based disaster management, lesson from Kobe and global perspective in disaster nursing and social innovation. This is my small profile. I was born in Okayama, next prefecture of Hyogo Prefecture. And I've lived in Kobe since 1996, just after Hanshin Awaji earthquake. At the time, I was a university student, and I went to Kobe University for bachelor degree and my master degree, and work for the nursing, volunteer, and many activities. And 2007, I worked on research as a researcher of University of Hyogo. That foundation or make the university fund the launch disaster nursing at the time. I will talk about later. Yes, and now I work for community member of Science, Japan Science Council and Japan Society of Disaster Nursing, and much more disaster risk reduction transdisciplinary approach. So I will tell later about World Society of Disaster Nursing launch 2009 in Kobe, but again the IS International Research Conference of World Society of Disaster Nursing this year, November 29 to December 1st. Please come back again to Kobe. At first, I would like to talk about the history of disaster nursing. Yes, the origin of nursing and the pioneer of nursing is by Florence Nightingale. they work on the Crimean War. From them, many relief efforts by nurse there, and after that, Red Cross effort and many hospital nurse effort in community, but no data, no research so far. In 1995, Great Hanshin Awaji earthquake, at the same time, 2 months after, Tokyo subway sarin incident occurred. At the time, so many hospital nurses have to go out to community and relief and in acute phase and recovery phase. Then lesson learned from the disasters. The Japan Society of Disaster Nursing established, and at the same time, in Nursing Association, disaster relief nurse and was trained, many nurses. And at the same time, and after that, the Center of Excellence Program for Disaster Nursing. What is a disaster nursing research and what is a nursing competency for community or in hospital? And they launch community volunteer nurse in front of supermarket and shelter and temporary house. And after that, they understand and needs the competency of disaster nursing and WHO Collaborating Center for Disaster Nursing and Emergency Response. This is the first of the world. Then, around the 2000, the undergraduate education for basic nursing curriculum, we educate disaster nursing in a baccalaureate degree. And this ICN competency they launched and the World Academy of Disaster Nursing established and master degree. But after 2011, Great East Japan earthquake occurred. We realized that we need paradigm shift of disaster nursing. We realize disaster nursing and make much more global leader or master degree program as well as local community nurse. Today, I'd like to introduce some of part of our works historically. First of all, I'd like to talk about disaster nursing definition. Disaster nursing involves the systematic and adaptable application of nursing distinct knowledge and skills preparing to disasters. It encompasses the creation in initiative aimed at reducing the harm to life and health resulting from disasters in collaboration with various specialized fields, multi-sector. This is the definition of disaster nursing. On the other hand, not only research is not enough. So I launched EpiNurse for much more implementation science and adaptation. So I'm founder of EpiNurse. The EpiNurse is with the aim of reducing health risk associated with climate change and natural disaster. And we will implement and develop initiatives based on care science to create safe social mechanism and environment in Japan and global. Today, I bring this book, but I forgot, I leave the room, so I will show later, but I published from SDG 3 series named Disaster Nursing. It's primary healthcare and communication in uncertainty. And that included SDG 3 series and offer multi-professional connection into disaster nursing. And that describe in Japanese experience of evolving nurse role in changing social context, aging country and aging and much more multiple risk and big hazard. back to the 2007, when we launched the framework of competency for disaster nursing in Japan, beforehand, in USA in acute this kind of competency for only acute phase and kind of critical nursing and emergency nursing. But lesson learned from disaster nursing of Hanshin-Awaji earthquake, we need not only acute phase, emerging phase, but also how to recover, how people can recover and rebuild their living. That is, the nurse must be vital role, we realize. So we model the competency like this. Much more important is fundamental attitude towards disaster nursing. Then we make the systematic assistance and provision of disaster nursing care or care provision. And then we should develop professional development, including knowledge and skill and judgment. At the same time, many disasters occur globally. This is the case of Indonesia in the Indian Ocean tsunami 2004. We collaborate with Indonesian Nursing Association, and in the book, my student describe the history and the work at the time of disaster, and they realize it resulted in overwhelming disaster, prompt numerous international organizations to revise and update their standards. These updates focus on enhancing cluster approach, refining continuity procedure, and strengthening emergency preparedness measures, they said. Then, Indonesian Nursing Association ANA President Professor Ahiruyani launched Indonesian Society of Disaster Nursing, and they also work still now much more focused on spiritual care, cultural care, and they develop own disaster nursing in the country. Then, at the time of Sichuan earthquake in China, they said, it was observed that medical institutions in the area impacted by emergency were not sufficiently aware or prepared to manage public health crisis effectively. Additionally, they lacked the capacity to respond to such emergency adequately. To address the issue, unique policy known as pairing assistance, adopted by various provinces in China, has played a pivotal role. This approach has significantly contributed to support and reconstruction effort in leading substantial improvement in hospital emergency first aid equipment, the overall emergency management system, and the emergency response training for medical personnel. Then, 2017, Typhoon Haiyan, Philippines occurred. That after Great East Japan earthquake, after 2 years, so many Japan relief responder trained and go to Philippines. I remembered. At the time, as they said, strengthen coordination response effort in disaster management involves training nurse specialty in disaster response, establishing clear policies and guidelines for emergency situations, and fostering network with disaster management agencies, they realized at the time. Additionally, implementing an organized system for volunteer recruitment and community coordination is vital for promoting volunteerism and ensure an effective disaster response. Equipping nurses with the skill to respond to emergencies is crucial for achieving the objective of saving lives, minimizing disabilities, and enhancing resilience among individuals and community in the face of disasters, they said. And at the time, the one leader in the Philippines, Sheila Bonito, in University of Philippines, she is also still now a professor of University of Philippines, and she worked with Philippine Nursing Association also. And now they make many e-learning and based on core competency for Filipino nursing and collaborate with health community volunteers. Then, just after Sendai Framework launched in March 2015, Gorkha earthquake in Nepal occurred. Yes, and we know what is Sendai Framework mean, understanding risk, and many governments for resilience, and need prepare. Of course, we need prepare and recovery, and many technologies should be required. We knew, but when I go to Gorkha earthquake, they might not still don't know about Sendai Framework and even though SDGs. But anyway, we collaborated with Nursing Association in Nepal, in Kathmandu. And they realized a key challenge in disaster response included limited manpower, financial constraint, ethical consideration, and ensuring the safety of nurses. In Nepal, where frequency of disasters on the rise, the development and enhancement of human resource and capacity in disaster nursing have become paramount priorities, they said. And at the time of Gorkha earthquake, I will tell later, but they collaborate with Nursing Association, collaborate with not only Ministry of Health, but collaborate with Ministry of Urban Development sector and many earthquake in Nepal. Many NGO, NPO they have, so collaborate with them in locally, and because the geographical challenges, so many geographical challenges and many vulnerability and health equity visualized. These 10 years, 15 years, since Hanshin Awaji earthquake until Great East Japan earthquake, Japan disaster nursing definition is same, but our idea, our research was changed. Because at the time Hanshin Awaji earthquake, that is urban area earthquake, many people, early morning, and no data, no research so far about disaster nursing. Anyway, the past achievement of disaster nursing since 2012, hazard-based, disease-based, immediate response, relief in acute phase. And my professor, Noriaki Aoki, is already passed away, but he calculate how 72 hours is very important, critical and vital role of emergency team. And he calculate cost effective of disaster response at that time. And he emphasized not unnecessary death, non-necessary death, not preventable death, unnecessary death. And we research about, anyway, make the report, lesson learned from past disaster. But for Great East Japan earthquake, that was not enough. So we discuss and research using Delphi study, focus group discussion with nursing leader and more disaster risk reduction leaders and another sector. And we launched the challenge and task after 2011. Transdisciplinary work is essential. Longer-term recovery is more essential. Community-based important. Seamless and continuous support is in local is very important, not from outside. But community-based development is much more important for resilience. And comprehensive approach and for vulnerability, policy recommendation is required by female or women's group and vulnerable group and so many subgroup. Everyone's call should call to action. And on the other hand, much more technology development these 10 years. So disaster ethics, because so many cross-sector, multi-sector response, many technology, many ethics, and many human capital. So how to coordinate this for disaster management ethically? This is our challenge and task after 2011. Yes, and on the other hand, HEAD, Health Emergency and Disaster Risk Management by WHO, very synchronized to our works. They call, after SDGs, after Sendai Framework, after Bangkok Principle, they call this more holistic approach, not evidence-based, risk-based, not rather than reactive rather than reactive to risk-based, proactive, not single hazard but all hazard, not hazard focus but vulnerability capacity focus, not single agency but whole of society. And most important is not planning for community, but planning with community is essential. And so we also collaborate with their initiative, and we realize we should go much more work with community. So we make that kind of paradigm change, the transformation of disaster analytical competency. Not only knowledge and competency, but should commit to outcome and need transformation in the community. So from the nurse management perspective, not only I know danger sign or I can cure patient, but also we can triage and arrange care for community people and need care, managing care using adaptive technology and human-centered. How manage care? Care is invisible, and for only not only self-care, but primary health care, and including public health. For that, we need not only disaster relief work, but also policy proposal and community-based disaster reduction DRR plan, and we should commit. For that, we recognize what is understanding risk. Yeah, for nursing, from the nursing perspective and insight, the hazard, we should escape from the hazard. We have to make people escape from the hazard at first, and after that, for vulnerability, protect survivor life and maintain health. And for capacity, how we can rebuild their living and their living environment and livelihood. That makes the action. For example, first aid, mental health care. That is the result of understanding risk. So we always make the beta version always, and adaptive technology, and make the plan with community. This is one example of the epidemiology surveillance system, because this is at the time of Gorukak earthquake. We went to the hospital at first, but they said, "Oh, that's no casualty, because people, there are no people here." And then we go to the primary health care center and mobile clinic, Yeah, they have no diagnosis, but many symptoms. And we go to an outreach to shelter. We realize no symptom, but many healthcare needs, basic healthcare needs, and many health equity, and no men, but many elderly women and children in the shelter. So healthcare needs is various and very different from the equipped facility. So we launched the EpiNurse at the time and monitoring. And we realized using the GIS, what is community, who is community, and where is community, and how to care. So we realized the geographical issue, because of a geographical challenge, so many blankets in Kathmandu, but no in Golkha area, for example. Many inequity occurred, so we visualize, and we work with community there. But many manpower shortage, and also fund, also and donation, also shortage. So, and this is the history of our works. Then, on the other hand, about the health sector and our disaster nursing research, we usually make this kind of matrix, because not only hospital, but healthcare in shelter and public health sector is required. Just after disaster, in the home, and after that, injured survivor moved to hospital and go back to temporary house and shelter again, or temporary house and rebuild the new house. But depend on the timeline, usually mental health occurred, infection disease occurred. Sometimes we can find the type or typically symptom something and needs a care. But not only human symptom and care or like a triage, but also we need policy recommendation for infrastructure sector, because this is challenges in Japan now, not the earthquake. As you know, January 1st occurred. So far, so many disasters since Hanshin-Awaji earthquake, we always experience secondary deaths, disaster-related disease deaths, not only directly deaths, secondary deaths. We very small data, because no tracking the people behavior. So that they only government have some small private information. Based on the private information, our colleague and our student, our Japan Society disaster nursing analyze the cause of secondary death. Not only psychological social stress, but issue related on disaster response. And that main cause is depend on the disaster event. And for example, VDT and at the time of Kumamoto earthquake, many secondary disaster events occurred. So the stress from the earthquake and the shocks, and in Japan now aging society. So anyway, we need seamless care and seamless medication. But so many population is aging, so not only dispatched disaster relief team, but also how maintain the hospital is essential now. And for that, the electricity and water and gas outage is very, very challenging now. So that means not only symptom or disease-based, but much more cross-sectional. How we proactive work, what is the priority, how to maintain immediately. We need to discuss much more for much more preparedness, more secondary prevention. So, on the other hand, nowadays in Japan, so many information systems already worked by government, by NGO, and many local government also. From the public health information management perspective, we know what kind of information is required at a disaster. Population overview and shelter and daily necessity, water supply, food, health status, and rescue facilitate place, and where is. And we need a timeline and mapping is essential for epidemiology. So to address the healthcare needs, first of all, we need situation check and medical support and sanitation. Then, after turning 3-day or 4-day turning point, we should change the item collected. Water supply information, distribute, not collect, distribute water supply information and kitchen information and bath information, daily information. We not only collect the data, but how to distribute the data, that's much more important to outreach to community so that people and survivors can work as self-care and protect their lives. So we focus on much more how to collect, but how to distribute, how to interact communication we can work. After this digital transformation era, we need this kind of transformation is very required to no one left behind. Yeah, so for that, yeah. And on the other hand, nurse itself have many big data. Local nurse, epi-nurse is not dispatched nurse, but local nurse worked in community as resident. They nurse as informant. They work experience much more, 20 years, 30 years living there. And they have knowledge about sanitation, not only disease and sanitation, but also culture and who they are. And when after disaster, at the time of disaster or disaster risk reduction in even that daily life, they can monitor what is change, what is social change, what is behavioral change, what is individual change. They can understand it. So they can check what is what's changing just before disaster event or after disaster event. Using this kind of data, they work from the data, from the insight. Epi-nurse work as caregiver directly, not only one manpower, but collaborate with multi-sectoral community, if they can communicate with them. Then, the data, what is the data insight for DRR? Of course, government know about hazard map and risk map and population statistics, many. But in local community, data insight for DRR is how familiar with the area, how they know about unique knowledge about in community, know about community and individual people, and how to the relationship, including in the relationship with people. And they, of course, know about perception. What is a risk? That means understanding the risk connected to perception. And using knowledge of local knowledge of DRR and adaptive technology, and that make disaster health risk reduction. Nowadays, for disaster nursing insight, various, this half circle model is social determinant of health model by economical epidemiology. For non-communicable disease, we analyze individual life factor, for example, exercise, training, and food habit, something like that. For much more occupational disease, we think, and community health, we think about much more social community network, where something. For environmental nursing, we need much more living, working environment, agriculture, and food protection, something. So we think about SDGs all. On the other hand, many social systems threaten based on threatening human security. So anyway, we think about much more SDGs apart for, but much more care to 1, 2, 3. 1, 2, 3, and poverty means clothes, food, good food, clothes, and living environment. We care that. And after that, after disaster, everyone lost this kind of SDG 1 or 2 issue occurred. So we need a nursing theory, not only epidemiological model, social determinant of health, but nursing insight. This is very famous Leninger Sunrise Enabler Discovery Culture Care Modified, the culture care model. Multicultural care model, really analogy of social determinant of health. We think this is culture of this community and how to care to people. For care or nursing care practice and professional care cure practice, we need much more caring and sharing and daring, very famous words. That we can share this kind of knowledge and insight. Nowadays, digital transformation, we can share this kind of knowledge as digital technology and digital transformation. So far, very difficult to share because unvisualize and calculate, and you not to calculate something, very quality issue. So again, we go back to Florence Nightingale and Primary Healthcare Initiative. Compare. So the green color is Principle of Primary Healthcare by WHO's 1977. One, fair distribution and access, that means equity, and citizen participation and multi-sectoral collaboration. We already experienced and implemented. But nowadays, the community is not traditional community, new society. So for new society, what we should do for fair distribution, but responding to the changing needs of vulnerable population we need. And citizen participation, not the community participatory, but citizen participation, how we make citizens to participate with non-closed community, and how to utilize information. And digitize information, and like SNS, and metaverse, and operating flexible system that involve the whole society rather than dividing roles. So much more cross multi-sectional, but operating a flexible system, open system of we call for collective impact, open governance, something like that. And not only appropriate technology, but also skills in using data to analyze the social structure related to vulnerability exposed by disaster. So how we can utilize for most vulnerable people, how to utilize, that must be in the, that is the one challenge of this digital transformation. Yes, and then I also publish this Society 5.0. 5.0 is one initiative in Japan for digital transformation. So that is Society 1.0, hunting gathering society, 2.0, agricultural society, 3.0, around 1970s, industrial. The Society 4.0, information system, now Society 4.0, much more, 20 years like this. Now, from now, in Japan, Japan now focus much more new society. But Society 4.0, that means they said, government say, a human-centered society that balance economic advancement with the resolution of social problem, a system that highly integrate cyber system and physical space, they call. So we think much more Nightingale in community, new society, not in the hospital, based on human security. So we wrap up the global issue and the local action. Yeah, nowadays, challenging is in Japan is aging and changing diverse value and much more intergeneration gap. Generation gap and intergeneration collaboration is required because the number of children is decreased also. So, on the other hand, nowadays, still in Japan, traditional society, gender issue, disabled person, many chronic disease there. And in globally, many people, even though not only in Japan, but also globally, they move and work, changing the work. And that is now core issue. What we should change the paradigm. And the current situation, yeah, government cannot understand by not only top-down monitoring, but so need long-term health issue and challenge have been consistent overlooked. So how nursing insight visualize for future and future DRR? That's a challenge. Then the self-care, so for that, our strategy should be shift much more self-care of people, lifestyle change, modification, using remote consultation, utilize remote consultation, even though disaster risk reduction and disaster response. And co-creation of decision-making with community. And much more, not only autonomy, or not local community, but global community. For that, our work should be changed to much more open governance and collective impact, using much more transdisciplinary and collaborate with another sectors. This is the one work, and this is a kind of innovation that in Japan traditional culture, we have diary. They can self-awareness of DRR, for example. At the time of disaster, what kind of symptom occurred, health challenges occurred. And they, not only the collecting data, but we make the book. This is the timeline log, timeline pop-up. You should do that after disaster. Check. And for example, how to recover. And this kind of guide, including this book. Now I make the application for that. And for the mapping, nowadays we can use the data insight by Yahoo. And we realize, using this big data, at the time of Kumamoto flood 2020, at the time of COVID, under COVID, we, using the people flow data, we found the people living in greenhouse rather than shelter evacuation center. They stay there. So after that, we realize not only hazard map need much more, where is safety area, where is, if people can go where, we can protect their lives. For example, toilet mapping, including toilet, at first change the mapping, open street map, and toilet mapping, and shelter mapping, food store mapping, something like that. We distribute the map, where is the toilet, where is the bus, something, many, gasoline stand. These work recognized by International Science Council, not only protection disease, but because if we make the evidence for medication or only health disease, we need RCT. But anyway, this kind of application to advanced science, they said, as a global public good, but nursing should need more transdisciplinary approach, not only interdisciplinary approach, but collaboration to transdisciplinary approach, and need knowledge society platform and open governance and open data of not only health but many multi-sector from the multi-sector. And grassroots process innovation and citizen science. Now we faced on this challenge, how to make the citizen science and make the evidence. And for that, youth leadership is required, and science partnership and new development field is required. This concluded by this book. I have book today. Yes. So, and on the other hand, because of COVID situation, ICN COVID ethics nursing change, not only with coworker, but also nurse and global health. So we work with not coworker, but global health. But this coordination is very difficult with technology. So we research now much more adaptive technology also. For that, this kind of demand material, immersive interactive exercise, sustained offline activity, and field work, this kind of cycle is really, really important and essential, not only lecture and desktop exercise. So we could develop this kind of works. Yes, and make much more develop agile application, not big heavy system, but agile application every day. And we develop much more application depend on the disaster, based on disaster response to disaster demanded. Yeah, this is one of meta-nurse we call. Yeah, we to integrate the information from the paper and make the, what is that, the text, from the text, with the visualize and on the make the place, or even though we need the programming, but we make the metaverse situation. This situation, Indonesian foreign student made. What is safe for Indonesian nurse and Indonesian people, for example, from this text. And we discuss and collaborate and another sector. Oh, this playing room and water and trauma care is most important. We all can understand immersively and can go to dispatch and make the consensus. like this. So anyway, create this risk perception among meta-nurse in intergeneration. Yeah, even though elderly people cannot use metaverse and VR, XR, and technology, but young people can do. But aging people know many perceptions. So how to integrate on metaverse. Now, for inclusion. And make the output to as AR and application, something. Yeah, already we make that. Yeah, so in conclusion, anyway, we need near future or climate change, much more cross-sectional data. So volunteer valuing as human asset for citizen science. So for nowadays, we launch NFT or kind of using AGI. If we use, you can use AGI and NFT, blockchain. This kind of technology can utilize for DRR, and because we make the citizen science and community participation and community DRR much more needs ecosystem, and we can predictive analysis for DRR with well-being, because of very various kind of data and their perception also. But on the other hand, evidence and business and research, something, this kind of, and international, inter-country, balancing various interests and based on the public interest. This kind of discussion and comments and making a consensus is very important. And further, so for that, real data most important, not just rapid assessment, but real data, how to monitoring using IoT, and how to update science and the governance system. Yes, thank you very much. And another discussion, and another next achievement of our works, and I want to update in World Society of Disaster Nursing. In main theme is rethinking disaster nursing in the changing risk landscape, primary healthcare to social innovation for planetary health. The next 2024, November 29 until December 1st, not only a seminar, but excursion in community. Excursion in community is the main session we plan now. Thank you very much.
Thank you very much, Professor Kanbara. Very informative lecture with broad scope, but incorporating many important keywords such as data-based approach, or the paradigm shift from a response to preparedness or community focuses. Maybe we have now 5 to 10 minutes for the Q&A or discussion with floors. Maybe you may have a lot of questions. If you have questions, please raise your hands and we'll, thank you. And if Japanese person, it's possible to ask questions in Japanese too. So open the floor to you. Any question or comments? Good. If nothing forced from the floor, let me ask some questions to Professor Kanbara from my side. I am interested in some focus of the community. The WHO also worked for the disaster reduction or health emergency response, and know some lessons learned from past experience of the disaster management. It is no global health security without local health security. We always have some global rule and regulations or the manual or theory. However, to implement that on site is always difficult. You have worked for the community so long time. You have, could you please share your experience or challenge to implement on site some challenges?
Okay, thank you very much. Very good question and critical challenge for us also. So our approach, for example, innovation from gender, from women, for example, I have worked with women's community for the RR more than 5 years, and work and discuss and data insight and big data and work with community, only women group. And they realize what is differences and from the general approach. And we focus, for example, in the Nepal, they cannot read the map. Not the shortage of knowledge, but shortage of knowledge of mapping. For example, map. This we should focus and intensive work for that. How women can read, or how invisible person can understand. This kind of interactive activity can outreach, and we understand their talent development also. So this kind of sense of human capital and talent development is very important for citizen science and community development, I think, and social capital, I think.
Thank you, Professor Kanbara. That lays another issue about the health workforce development, capacity building. Maybe there is no standardized way to develop the capacity. What would be the possible challenge for you for the capacity building for the?
Yes, I think that, and for that, I think much in basic study, and from the children, and what kind of talent development and capacity and education, I think go out to community naturally, and not only in the hospital at first. If bachelor degree of nursing student, for example, so our college first practicum, not in the hospital, but go to community now and communicate with community people. And from this kind of experience, many capacity building is changing, I think.
Thank you very much. This could be also the possible collaboration with a multi-sector approach or interdisciplinary approach. Maybe other sector also have challenges to capacity building in your side. Kind of your model could be applied to other sectors of work also. Any question from the floor? Thank you. The lady. Microphone, do you have any? So could you tell your name and the institute, and then the question, please.
Thank you for your presentation. My name is Adam, and I'm from Korea. I'm interested in intergeneration gaps, what you mentioned before, because we are also, my country is also experiencing like aging society like Japan. And in terms of data, like access to data, is there any training for aging people to learn how to use basic digitized tools or like technologies? Is there any?
Yeah, that is challenging. Yeah, so and first 5 years ago, not many people, aging people, elderly people don't have smartphone. But nowadays, anyway, please use smartphone at first now. After that, the DX occurred. Yeah, if you use the smartphone at first, they can get to that, they understand how convenience. After that, automatically they can, and they naturally they understand much more, utilize application and collecting data is important, something like that. But before that, usually I already showed that the traditional diary and healthcare giver check and consultation together, and nurse input the data. And several years, this kind of effort we did. Yeah, so maybe step by step, not straightly we cannot change, but step by step and adapt to the aging society now, I think. And at the same time, technology development. So how to harmonize that? That's important. Thank you.
Thank you. Any other questions or comments from floor? Okay, it is time, coming to time, but I want to say that it is very good to know. Oh, any question? Oh, please. Microphone. On the back side.
Thank you very much. I'm sorry I have a bad voice because I have a cold. I'm a professor emeritus, University of Hyogo. From your interesting lecture, I reaffirm the importance of disaster nursing, even though I'm not from that discipline. When we are now looking at disaster-affected area in Noto, I have to answer myself this question: why this disaster-related, not direct death, but disaster-related death? You mentioned, of course, there are a lot of problems because this is a very complicated, composed kind of causes. Other than very difficulty in accessing to this area because of the disruption of roads and so on. From the viewpoint of disaster nursing, what are the main problems about causing this thing again and again? I should say, we experienced this thing in Kumamoto, quite a big problem. This is one question.
Yes.
Just I don't need a perfect answer. Your
my opinion.
yes, your reflection right now. And another thing is very good project about epinurse. So, are there any activities of this epinursis in the currently affected area?
Yeah.
Thank you.
Yes, I also work in the disaster area now. Many my friend and colleague work on there. Yeah, thank you very much. The question I really appreciate. I always think about your question. Yes, and my I think main issue is what we should sustain. We should sustain at the first the general issue. But usually, after lesson learned, what we can do, we evaluate what we can do, how we should recover. But we do not sometimes think about how we can do sustainable work. So, and always everything, always they faced on the government, local government people faced on same answer. Yes, that's very important, but we cannot do now. Why? Because we should much more need action after action review, and we have to make more general. We should make the preparedness much more general. That can adapt to next disaster, generally or sustainably. Otherwise, we always in Japan, because many disasters occur, they understand, many things occur, many lessons learned. But for that, many clean evacuation center. But evacuation center is not fast, but clean water and safe water and toilet, this kind of human health basic needs for nurse is required. That is not shelter. So we should much more translate much more sustainable or common work in daily life as for the RR, I think. Thank you very much.
Thank you very much for your question, Professor, and also answer by Professor Kanbara. Because of time, I have to close this session now, but I want to say thank you very much, Professor Kanbara, for your speech, and it's very good to know that you will be the conference organizer of the World Society for Disaster Nursing in this year, and you are the person who are very keen to collaborate with other sectors here. Tomorrow's IRP forum participants, many people are here, and it's very motivated message from you. Thank you so much, and I hope that tomorrow is a success, and also this afternoon success of the IRP forum and side events. Thank you very much.